When faced, how can patients know they're armed with everything they need to guide their treatment? Foundation Medicine has developed a comprehensive and validated approach to identify clinically relevant genomic alterations in a patient's cancer, providing doctors an opportunity to personalize treatment options, including targeted therapies that may be more effective and less toxic than traditional chemotherapy. Our approach begins by looking at genes, oftentimes hundreds, that are known to be associated with cancer, using a tool called next-generation sequencing, or NGS, to help find alterations in the patient's DNA that are causing the cancer to grow. Alterations can happen anywhere in the gene, and there are 4 major types. The building blocks of our DNA may be substituted, inserted, deleted, duplicated, misplaced, swapped, or just plain broken. In all of these cases, the cells may end up working differently, causing a tumor to grow. Other tests, such as multi-gene hotspot NGS tests, only look for 1 or 2 types of alterations in predefined parts of cancer genes. Hotspot tests, therefore, may identify common alterations, while overlooking unanticipated but potentially important and actionable ones. By contrast, Foundation Medicine's comprehensive genomic profiling approach broadly analyzes the tumor genome to identify clinically relevant alterations and potentially expands your patient's treatment options. We offer a portfolio of comprehensive genomic profiling services for patients with solid tumors, hematologic malignancies, and sarcomas, including a liquid biopsy service for patients with solid tumors. Our approach analyzes cancer-relevant genes to detect the 4 major classes of alterations specific to an individual's cancer. Some of our services also measure specific genomic signatures, such as tumor mutational burden and microsatellite instability, which can help inform the use of immunotherapies. To find these alterations, Foundation Medicine uses advanced algorithms developed by some of the world's foremost cancer genomics experts and computational biologists. Our approach combines this expertise with our database of cancer genomic insights, one of the world's largest, to continually optimize and improve our algorithms, allowing us to efficiently and accurately discover the unique alterations and genomic signatures in a patient's tumor. We then issue a clear, in-depth report with insights on the patient's genomic profile, as well as associated targeted therapies, immunotherapies, and relevant clinical trials. The end result? Doctors have what they need to make a more fully informed decision, and patients have the assurance that no stone is left unturned in their treatment.
Good afternoon. Another course that we have together. So on behalf of the Cancer Research Group, Collaborative Group, and Arab Medical Association Against Cancer, we are happy to have you in our 2021 ABC Oncology educational courses. Today, our course will be about precision medicine. I'm welcoming all our speakers, all our panelists, all the attendees from all over the world, where we have more than 540 registered persons. So you are all welcome. I would like to thank also and every time Science Pro for their excellent job and work. And now if Dr. Evelyn with us, may I, okay. So I will introduce Dr. Evelyn Helou. She is a hematologist, oncologist at Lebanon Hospital, Jitawi. So Dr. Evelyn will talk about how can biomarkers be a tool for targeted cancer therapy. So the floor is yours. Please note that all our activities bilingual in French and English. Just if you want to hear it in English, in the block of interpretation, just click and change for the language that you prefer. You are welcome. Please, Dr. Helou.
Thank you, ABC. Thank you, Amak. I will share my screen. I will tackle the subject of biomarkers as a tool for targeted cancer therapy. What is a biomarker? A biomarker is a biological marker. It refers to a broad range of measures which capture what is happening in a cell or organism at a given moment. Biomarkers are objective medical signs as opposed to symptoms reported by a patient. Biomarkers can be physiological, radiographic, histological, and molecular. The oldest biomarker is pulse measuring. In Mesopotamia, it was included in the Gilgamesh epic around 2600 BC. My screen is blocked. In ancient Egypt, a papyrus dated circa 1500 BC described the pulse as the voice of the heart. I will focus on biomarkers guiding the management in colorectal cancer. The driver mutations, KRAS, NRAS, BRAF, NTRK, the tumor cell surface antigen, HER2/neu, and the DNA repair deficiencies, MSI. We are witnessing a genomic burst of CRC, l'éclatement génomique in French, with a growing landscape of oncogenic targets with promising opportunities for the future. EGFR is a well-known cell surface receptor highly expressed in around 60% of CRC with no predictive response to anti-EGFR drugs. This led the investigators to dissect the MAP kinase pathway downstream from EGFR, and RAS wild type turned out to be the true biomarker for activity of anti-EGFR therapies. This explains the selective approval of cetuximab and panitumumab for RAS wild type tumors. What's new in this area is the possibility to re-challenge with an anti-EGFR in the third line setting according to circulating tumor DNA. In fact, treatment with EGFR inhibitors in the first line rapidly eliminates RAS wild type sensitive clones. After disease progression and due to the administration of second-line chemo without anti-EGFR monoclonal antibodies, RAS mutant clones progressively decay, inducing the proliferation of RAS wild-type cells again, detectable on circulating tumor DNA. BRAF mutant colon cancer represents 5 to 10% of sporadic CRCs. They are almost exclusively non-overlapping with mutated RAS. 90% of the mutations are in codon 600 with change of amino acid valine to guanine. This mutation confers constitutive kinase activity. BRAF mutations are more frequent in women, smokers, mucinous histology, and in the right colon. They are frequently associated with peritoneal, lymph nodes, and lung metastasis. And a third of the cases are microsatellite unstable. BRAF mutation is a marker of worse prognosis, with a survival 3 times shorter for BRAF mutated CRC. Regarding standard chemotherapy, it has been demonstrated that there is no association between the presence of BRAF mutations and response to oxaliplatin and irinotecan. However, the predictive role towards anti-EGFR agents is still a matter of debate. How can we target BRAF? Inhibition of BRAF alone has limited activity because of pathway reactivation through epidermal growth factor receptor signaling. In this recent trial, PFS, the primary endpoint, was improved with the addition of vemurafenib. The response rate was 17%, with a significantly better disease control rate of 65% versus 21%. HER2/neu is a member of the signaling pathway family of receptors. It is overexpressed in 3% of CRCs overall and circa 10% of RAS-BRAF wild-type tumors. It is not a predictive of worse prognosis, but it is a predictive of low response to anti-EGFR. This meta-analysis shows that double targeting of the HER2/neu with lapatinib and trastuzumab is better than monotherapy with each, with the most promising combination being trastuzumab with the small molecule tucatinib. DNA mismatch repair results in the accumulation of base pair mismatches across the genome, particularly in highly repetitive regions called microsatellites, resulting in genome instability. This is the hallmark of Lynch syndrome, which confers the best prognosis in stage 2 and virtually no benefit from 5-FU. It can be diagnosed by either IHC, showing loss of expression of one or more of the MMR proteins, or by PCR or next-generation sequencing NGS, looking directly at the gene's deficiency. Keynote 177 is a phase 3 trial showing a PFS superiority of pembrolizumab in MSI high CRC versus chemotherapy with or without EGFR target treatment, even with a permitted crossover to pembrolizumab. The response duration was unprecedented. In conclusion, we are moving towards an integrative approach in CRC, and with the success of the integration of biomarkers in the treatment strategies, we are witnessing a paradigm shift in clinical trial design. With shift from moving from traditional umbrella trials specific to a histological subtype to basket trial specific to one molecular alterations. Thank you for your attention.
Thank you, Evelyn, for the excellent presentation. So I would like to present our panelists. They will take care about the discussion after the two lectures that we have. Dr. Hamping. Dr. Hamping, you know that he is hematologist oncologist at Hotel Dieu de France University Hospital, and Dr. Abdelghani Tbahi, I don't know if he could join us or he couldn't because he has some things to do. And Dr. Ashwaq Alayan, Head of Adult Medical Oncology and Director of MENA NCCN at King Abdulaziz Medical City in Saudi Arabia. So I will present now our next speaker, Dr. Wafa Abu Al-Ainain. She will talk about challenges of personalized medicine, translational science, and clinical development. After the lecture, so our panelists will discuss the content of the two lectures, and we'll have the questions and the answers. Dr. Wafa, the floor is yours.
Dr. Wafa, بس please إذا فينا نشيل الميوت. We are not hearing you.
Okay, now it's good.
Yes.
Okay, I will start by thanking you for giving this opportunity for the ABC Oncology to share some of our knowledge. And also I would like to thank Dr. Sami and Dr. Fadi for organizing and allowing this educational session to be ongoing. I will share my screen now.
You are welcome.
I'll take this one. Is the presentation on the screen now clear?
Yes, it is.
Yes.
Okay. I will start by the presentation that I will go through is about the challenges of personalized medicine, translational science, and the clinical development. First, I will start by giving a small introduction of what is personalized medicine. So the personalized medicine is based on using an individual genetic profile to make the best therapeutic choice. By facilitating prediction about whether the person will benefit from a particular medicine or will suffer from side effects. I have a problem with my presentation. I cannot shift to the next slide.
Take your time, Dr. Wafa. No problem.
I have problem. Oh. Okay. The importance of personalized medicine, it has an impact on prevention, diagnosis, and treatment of patient, which will allow early detection of patient at risk and improve preventive measures. Also will give accurate disease diagnosis, enabling individualized treatment strategy. Also, for accurate treatment as well, to improve outcome through targeted treatment and reduce side effects. This will take us from the practice of one size fits all into testing each patient and treating each patient based on their unique genetic profile. The personalized medicine has impact in different areas. It's not only for oncology or metabolic, but also it is for neurosciences, respiratory, and infectious disease. The majority of practices and people hear about it more in oncology. And this is the area that I'm working in. So most of my of the examples that I will involve in the presentation will be about oncology. One of the most important start for successful personalized medicine in practice is to have a multidisciplinary team meeting, discussion, and collaboration. And this in oncology that will include pathologists, psychologists, biochemists, people from biochemistry, radiologists, genetics, from all different areas in the medical field. And this is important because that at the end, when the decision is made, that will give the correct answers for several questions. Which disease to be, which test to be done, under which circumstances, and who should order the test. And for example, in solid tumor, the decision will be made for which biomarker to be tested by the pathologist. It is important because once we make the decision, once we test the correct biomarker, we will make the correct targeted therapy choice. The targeted therapies will have different outcome and action in the body, whether by a cut of blood flow to tumor or to stop the pathway at certain gene, activated gene, or target defects on cancer cells, carry other drugs to tumor, or cause cell death. As I said earlier, the importance of targeted therapies is to reduce the side effect, and that was observed across a long time, where most of the diseases were treated by chemotherapy, and that has a huge side effect on the patient and pain, while recently or in the past years, the targeted therapy has improved the patient life and the quality of life. There are several stakeholders in personalized medicine that play important role to make it success, whether in the medical or in factories or payers or in the government or in data analysis or in also drug discoveries and pharmacist. This is the classical stakeholder presentation for personalized medicine. While we can say it should be more expanded, because in order to have successful treatment for each patient, we have to involve also charities, institutes, universities, education, labs, the patient himself or herself, and the family around. With all these advantages of personalized medicine and where the medicine have reached with treating patients, there are some challenges facing the implementation of precision medicine or personalized medicine. In addition to, as we have more people involved, that will increase the challenges. I'll try to go through it in short. The top 3 challenges are insufficient technologies, limited knowledge, and gaps in research are the major obstacles to adding precision medicine to routine clinical care. And each one of them have several, and under it have several challenges as well. Starting by insufficient technologies, having a diagnostic lab, genetics, including molecular and cytogenetics, with different technologies, that one of them will cover the limitation of the other in order to test all possible sample types and with all sensitivities, it is a huge setup and it needs a big and planned infrastructure. All these techniques and technologies are important. One of these limitations that we can have from all these technologies, whether it is with electrophoresis, LMPA, which is fragment analysis, real-time PCR sequencing, high resolution or chromosomal analysis, we can face the analytical sensitivity that can result in false negative if we use the technology wrong. Like, for example, we can have real-time PCR and NGS technologies have the best sensitivities in molecular, while Sanger sequencing cannot be fit for all somatic detection of variants. The other challenges that goes under the technology, that the cost, this is to have all these technologies in one place under one roof and to have the infrastructure for the data collection. It is a huge amount of cost, but at the same time, it's very good investment because it is going to be costing while preparation, while implementing the test. But in the future, once we have all the setup in place for personalized medicine, that will reduce the whole cost for healthcare. And this is very good investment in medical field. I have to mention here that under the cost umbrella, in addition, beside the technology, it's also the drug itself. The drug itself to deliver to the patient, it is cost, it's high cost and expensive. Also, developing the drug is costly, is not cheap. Also, if there is a third party will be involved in delivering the services for the patients, like insurance company, that will be expensive too. For these technologies, like real-time PCR, Sanger sequencing, PCR, those are all considered as single gene testing. And those, if we will go for testing, for the setup and the workflow in the lab, if it is going to be considered to be based on single gene testing, that will be very costly, very high in cost. It will have very low amount of data collected from the patient. Short fragments will be tested. The sample volume will be consumed highly. The analytical sensitivity that we mentioned as well. And also one patient will be tested at a time. And in addition, to complete the testing of a panel, for example, 10 genes that might take a long turnaround time. So the scientists and researchers, when they applied the NGS testing, which improved a lot in molecular testing for patients, it has advantages. I will mention the advantages, like for small panel that can detect up to 55 biomarker in one go. And also several patients will be tested at the same time. It's quicker for the turnaround time with very low DNA and RNA input. I'm sorry. So what is NGS? What is the NGS? The next generation sequencing is a method using array-based sequencing, which combines the technique of Sanger sequencing, but processing millions of reactions in parallel, resulting in a very high speed and throughput at reduced cost. Here we are sequencing millions of reactions in one go that will end up by generating a huge amount of data. This data, the challenge in precision medicine, is where to store this data. So the data storage is one of the challenges that we have in precision medicine. This data to store, it needs this here. The government, as I said, is one of the stakeholders, is can control the use of the data storage capabilities in each place. It might be a limitation or a challenge in my country, but it's not a challenge in other country. For example, whether using local server with high storage capability or a cloud-based. In Qatar, for example, we are not allowed to use to store any data in the cloud or to use any software uploaded in a cloud, because we have a data security, patient data security policy. Also, all this data collected, the providers need to have a digital tool to make sense of all the data that we have collected, and these technologies must be implemented in practice. So artificial intelligence platforms have emerged as practical tool to enable the use of precision medicine. These technologies can also bring new challenges. So databases, having bioinformatics tool, and having standards for using using the artificial intelligence for interpretation and data analysis of the patient. Here, making technology work for patients and developing the artificial intelligence with algorithm that can analyze the databases to help doctors with diagnosis. But this is, in practice, anybody doing the data analysis from NGS, it's not always dependent on softwares. The human working in data analysis and issuing the reports facing a big challenge in order to compare the results that are found with the databases available and the report based on guidelines, whether NCCN or CAP or ESMO, with all available resources. The other thing that can be a challenge out of this huge amount of data is the incidental finding. The patient will be tested for or screened for one disease, and the possibility of finding of another life-changing disease may be identified. The second point with the challenges with the precision medicine is the limited of knowledge. whether for the doctors, for the medical students in universities, or patients and families. The doctors, the primary care physicians have increasingly had to put clinical context around patients' test results. And many of them, they didn't receive enough genetic information when they were in universities before practicing. So for that, the increasing training and knowledge for students in the universities within their medical school program, it will be a very good option to overcome this challenge. Also, the patients and family to be involved in decision-making affecting their own health. The last challenge, based on the three main challenges that we have mentioned earlier, the gaps in research. I will take the NTRK as an example for the gap in research. So the first time the NTRK was detected in colon cancer, it was in 1982, while it was reported in 1989. 13 years later, a group of scientists have found that this is important. This gene is important, and it has been showing translocation in different solid tumors. So they studied it more. And in 2018, it was one of the most important discoveries and got the FDA approval for the Vitrakvi treatment, which applied for most of the cancer types if they have this fusion. The other thing with research is an area of competition. Many groups of researchers take it as competition rather than collaboration, and that make it a little bit challenging. During patient care and sample follow-up, as I mentioned earlier, we are working in sequences. The patient starts with the physician in the clinic, then he will go to the surgery for sample collection. The histopathologist will examine the test and order the molecular testing. So it is a full sequence. It is a long journey for the patient. And here from our everyday practice, we have this challenges for applying precision medicine, which is fixing the tissue in formalin, have going through a different fixation temperature, infiltration, and all this procedure will affect the quality and the quantity of the DNA. The other thing is the sample collection. Many patients refuse to go through invasive procedures. And this is a challenge for the doctor to convince them that this is very important. And the other important point, which site to be tested? Are we going to test the primary site of tumor or the metastatic site of the tumor? Also, if the metastatic site is on the bone, for example, it is really challenging to test it for molecular biomarkers, because the decalcification that is applied to the sample after collection, that will wash out all the DNA. If the patient tested positive, it is, if we will take the risk and test the sample, it might be positive. But if it is negative, it means inconclusive, because we don't know how much of the DNA has been washed out. The other thing that from a clinical side, this is mostly a technical side, but from the clinical side is when the patient is treated with different drugs. I will take here the lung cancer as an example. With all these discoveries across the years, this is a presentation for the past 20 years, for example, all these discoveries of treatment for patients and changing in the guideline, still the patients after treatment, 16 months or 18 months, they will develop resistance. Some drugs have been considered to be used as second line, like osimertinib, for example. If the patient starts with the first line tyrosine kinase inhibitors for EGFR, and then they develop for example, T790 mutation, they are eligible for the osimertinib. If the patient had never received any treatment before and start the osimertinib as a first line, also this is very good because we will overcome this challenge with having resistance from T790, but still from discoveries and monitoring the patients, other genes, other mutations will be involved. And if you see it here, this is an example I give in lung cancer, whether the drug is used as second line or first line, the combination and the possibilities of the resistant mechanism is different. So every time we have to apply and test the patient again. That will take us through the whole scenario of rebiopsy, testing patient, and data storage, because first time you have all these data generated, data storage again, and through all these challenges. With this slide, I come to the end of my talk. I hope you enjoyed it. And just to give a quick summary, so the importance of personalized medicine is to give effective treatment for each patient based on their genetic profile to improve their health and quality of life. The challenges that we are facing with personalized medicine is insufficient technologies, including the technology itself, the cost, limit of detection, data storage, artificial intelligence, data analysis and interpretation, and incidental finding, the limited knowledge, including all players within the hospital and the family, research gap, and in addition, other technical and clinical challenges. With this, I come to the end of my talk. I hope you enjoyed it, and I'm happy to answer all your questions later. Thank you.
Thank you. Thank you.
Thank you. It was excellent. I think Dr. Sami is not available. So now it's the end of the first session. Maybe our dear panelist can lead the discussion.
So thank you for this two great presentation from Dr. Hello, Dr. Abu Al-Ainain. So my first question is for Dr. Evelyn Al-Hello regarding the biomarkers in metastatic colorectal cancer, Dr. Hello. Today, how you will perform it practically? Do we go directly to NGS, for example, at diagnosis, or you will do it sequentially, the testing? So today at first line metastatic colorectal cancer, what are the biomarkers that we should do from the beginning? And you will repeat after progression to test other biomarkers. So what will be your attitude in the management of metastatic colorectal cancers?
Thank you, Dr. Ampik, for the nice question. Ideally, I would favor a tissue biopsy with the NGS at the diagnosis, and then during the progression of the disease, maybe we can, if liquid biopsy is available, maybe we can look at liquid biopsy, because it may give us more information about the heterogeneity of the disease. So this is what I think. This is ideally. What about you? I would like to know the opinion of the other panelists.
Honestly, today, after the approval of pembrolizumab in first-line MSI-high colorectal cancer, metastatic colorectal cancer, the MSI become mandatory to be done from the beginning. In our daily practice, we are doing it already, but now it's really for the management and the treatment, the immune checkpoint inhibitors become in the first-line setting. Now the question is to do in colorectal cancer well-defined panel of some genes or to go for a comprehensive genomic profile. I think today the targetable biomarkers in metastatic colorectal cancer can be done in a clear panel. So the clear panel here is to have the HER2 amplification or mutation, it's important, to have the NTRK, to have the KRAS, NRAS, BRAF, the MSI, and to have the POL. Those are the targetable biomarkers in metastatic colorectal cancer. But for sure, it will be interesting to see at the progression now with the rechallenging the anti-EGFR, it's really interesting to do, as you mentioned, Dr. Hello, the liquid biopsy before the third line. And the cricket trial is really interesting trial where we rechallenge based on the liquid biopsy if we have RAS wild type. So today also, as you know, we are leading a trial in USG on biomarkers in RAS after the progression to see if we will have change RAS status. So thank you for Dr. Hello. My question for Dr. Abu Al-Ainain, I don't know if there is another panelist that wants also to interfere or give his opinion. Dr. Farhat, we have somebody else with us, or I continue?
Yes, you can continue, but when you finish, we'll give some question. Go ahead, Hampik, dear.
Okay. So, Dr. Abu Al-Ainain, today in the Arab world and in the region, every center wants to do his own NGS and develop his own platform, because unfortunately we don't know how to collaborate together between centers or between countries. And this is today a big issue. For example, when I was working in France, you know that in Paris, for example, we have 2 to 3 centers that are doing specialized testing. For example, the lung NGS is done in one center. So all the samples from 12 million people are sent to this center to do. For example, the BRCA for breast cancer is done in another center. Unfortunately, in Beirut, we have more centers than Paris, and I think this is in the other countries. So I think the organization of the personalized medicine is a big challenge. So what is your experience in your country, and how also we can counteract this very important challenge also, because we want to have the NGS today needs many samples to work in a parallel, and each center should have an expertise to have the best results in the technique and in the analysis also. So what is your comment on this point?
Yes, I agree with you on most of the points, that we have to have one center that have all the expertise in order to have the delivery for patients with high standards. Multiple centers will result in performing the test and reporting in different standards. In Qatar, we have only one center lab for whole Qatar, serving the whole population. We're not big population, but we have only one center, the Diagnostic Genomic Division in Hamad Hospital, providing the NGS testing for clinical reporting and impact for the patients.
Excellent.
Thank you. Thank you both, Dr. Evelyn, Dr. Wafa. Thanks, Dr. Hampik. Just concerning the challenges, I think that Dr. Wafa went through the majority of these challenges. Personally, I think that all this problem of the absence of collaboration and the intention to shine by doing it by ourselves is normal, and with time it will be organized. And in one of our future session, we have put as a title the cooperation between different centers, how it might be possible. So maybe we will reach that a day. Dr. Abu Al-Ainain, I understand very well that the major is the economical issue the major one or not. I really think that the expertise is very important. I think also that the quality, since the method is difficult, the quality and the results, the positivity, false positive, false negative, is it frequent? So I have many questions. Do you think that the economical challenge is one of the most important, as I presume? And do you think that the quality also is really important problem in our practice or not? So two questions.
It is very good and very difficult question. Actually, for the economy and the cost of having the setup and the infrastructure is the key for implementing the personalized medicine. Without implementing the technology, without implementing the like the softwares and all the tools required, the expertise alone will not have the chance to analyze any data. They are important, and we have to spend money also on people working and for training and for visiting other centers to raise the standard. But first we have to make like a setup, a proper setup that will be really costly. It is ahead of, I think, the cost will be ahead of the other challenges. The other challenges can be improved. While
So what about
the economy,
quality?
if we don't have enough money to set up, then this is a big challenge.
So any idea how to overcome that? We never thought about doing, for example, going from many centers to ask, I don't know, these big pharma to participate in a trial to create. They will be interested.
This is important, Dr. Fadi. As I mentioned, now the list of stakeholders for personalized medicine has been expanded. It's not only for people working with the drug development and in the hospital. It is expanded also for charities, for institutes, for different people that can contribute on that.
So you have any idea to proceed with, to create an activity, to go with a proposal now from this platform? We have to think about it. So we'll keep it for later on. Thank you. And what about the quality? Do you think that we achieved a good quality? Because NGS is very hard to perform, to my knowledge. I don't know. I'm not really very expert in this field, but are we at a level, Dr. Hampig can help us, are we really at a level that we can be comfortable with, that really we achieved a good quality by doing and reading NGS in the region?
I think in Lebanon, we have many PhDs of really high levels. One of our team now is in Germany working with Centogene to analyze, because the part of analysis and interpretation of the results is the cornerstone of giving high quality results, because the technique is not really so difficult. So the technique can be done with well-trained people, but the main challenge of good results remain the interpretation of those results. So we need bioinformaticians, we need PhDs that are well-trained in big centers to present the very important results, mainly when we are talking in big panels and when we are talking in somatic. The germline is a little bit easier to do the interpretation, but when we have the somatic, is a little bit complicated.
So it's just for the question of Dr. Fadi, Dr. Hamping, I think you have the experience that all we know economically is very important and the cost of the test is very high. So I think you started to have part of the tests in Lebanon and then have the collaboration with the international institution to complete the test. Do you hear me, Dr. Hamping?
No, we had the connection was not clear.
I'm talking about if we couldn't do the complete analysis in our centers, what about the collaboration with other international centers? So we can do the first step or second, 1, 2, or 3 steps in our labs and then collaborate with the international centers to follow with the results.
I totally agree, but I think also, Professor Khatib, that our role today, we have really well-trained members of our teams in all the region, and we are capable to do a formation to our teams to be able to do it locally. And this will be our aim for the next few years, to have really well-trained people, PhDs and the pathologists, to collaborate together and to do homemade results. So I think for a certain time, we need collaborations. We need to do meetings oriented to do well-developed caliber person. And I think in 2-3 years, we will be able to do it in our countries very easily.
Dr. Khatib, dear panelist, can you take the questions from the audience? There is a few questions, please.
Can I add to Dr. Hamping? It is also if participating in some international standard programs like CAP. We are CAP accredited laboratory that also will increase the confidence by performing the test independently from any other institute.
Totally agree. CAP, CLIA, and other validation are really necessary. Accreditation is really important today to be on international standards. This is really essential. And when Professor Farhat was asking to collaborate with pharma, today pharma can't collaborate if the laboratory is not really well accredited. So this is also important issue. We should be more usually accredited in our labs, and also our colleague in our lab in Lebanon is accredited, and also in Qatar is accredited. So this is important step for us. So Professor Khatib, you will take the question, or I can take it? How do you want?
You can take it. You can take it.
Okay. So
I need a translation for this question.
For patients with both HER2 positive and wild KRAS metastatic colorectal cancer, any data combining anti-HER2 EGFR drugs together in the second line? The question for Dr. Evelyn El-Hello.
Yeah, about the question, thank you for the question. Not to my knowledge in clinical studies, there are preclinical studies, but as far as I know, when we want to build a trial, a rationale for a trial, we try to associate drugs when the two pathways collide. When there is one pathway that can overcome the resistance to the first pathway. And this is why, for example, we talked about BRAF and anti-EGFR. HER2 and anti-EGFR, I don't see what's the rationale to combine in the optic of something overlapping and resisting the other pathway. So this is my answer. And now about a drug that can hit both pathways, we have the tucatinib that goes against the intracellular tyrosine kinase, tucatinib and the family, the patinib. This maybe is another way to avoid using monoclonal antibodies, but I don't know if any other panelist has another view of the subject.
I will add simply, Dr. Evelyn, that it's one of the challenges that has been mentioned, and also Dr. Wafa talked about that, and Dr. Hampik said the interpretation. We need people knowledgeable in this field, and in some cases you might have many alteration, mutations, amplifications, or others, and here you will be glad to know which pathway is the driver one. So yes, it's true. It's not easy to know which pathway is the driver, which mutation which alteration is the driver one. But here we need for the knowledge of these guys who worked a lot in interpretation of the data. But what we know, for example, now that when we have let's say an EGFR mutation, for example, in lung cancer, it's probably the driver, the dominant one. So remember, we can have many alteration, but some of these are more driving the tumor than others. So in this case, the HER2 positivity. So if you have KRAS wild type or mutated, and you have HER2, probably the HER2 is here the driver mutation. So you have to go for it. Now to combine with other, I don't know the rationale. It needs more a specialist in such.
Professor Farhat, totally agree. I think that the HER2 positivity is usually associated with the triple wild type, KRAS, NRAS, and BRAF. So as you mentioned, the HER2 will be the driver mutation in this case, and consequently targeting the HER2 alone with dual target today with the Heracles trial combining lapatinib and Herceptin was really interesting. So in this case, I think combining anti-EGFR and anti-HER2 is not really well studied. So in the second line, in the first line, we are using the anti-EGFR in this case, and in the second line, based on Heracles trials, we are combining lapatinib and Herceptin, and now there are many studies with pertuzumab also.
Nevertheless, we will find with time that combining the anti-alterations pathways will be important. So just to say that we need more time to understand this mechanism, how it's escaped, because when you inhibit one pathway, you remember that another pathways will try to adapt in order to give the cell the possibility of survival. So like in breast cancer, if you suppress the estrogen pathway, you will have other pathways activated in order to survive. So it's a long learning process. Now let's proceed to other question, Dr. Hampik. A question to choose, which one to choose among the NGS companies or tests? Very hard question. Anyone will dare to answer?
I think this is difficult to have one answer. First of all, it will depend that the center that will be testing, are they offering the NGS for targeted genes related to the disease, or they are just offering whole exome, for example, which will be in most cases unnecessarily. Also the cost of the test will play a role here in which one to choose. I would always recommend for all patients, if they have chance to choose whether to do it for targeted genes, actionable genes, or for whole exome or a huge panel, I prefer the actionable genes. Otherwise, it's going to be, and we will end with the data that we cannot use for treatment of patients.
This is the debate between the companies. One is saying that I do everything, the other say that I do the actionable.
Yeah, I test only 100. The other company will say, "Oh, we are better. We test 350." Well, okay, but the 100 it's more.
Again,
having more impact.
Again, it's a long debate, but if you want to understand the mechanism of resistance, maybe you have to understand the full, to get the full picture. Because when you have your only targetable mutations, you understand, you know what to target. But when you have the whole picture, it might be different. I don't know. I'm supposing. Okay, Dr. Hampig, other questions?
Yes, we have another question to Dr. El-Hello. Why routinely we don't test PD-L1 in metastatic colorectal cancer despite the revolution in PD-L1 medications?
We should, because the FDA approved pembrolizumab first line based on the Keynote 177. But I think it's for access. The reason is more the access to the drug, but actually we should.
Sorry, can I ask a question? Is it approved for metastatic colorectal cancer, or it's the PDL medication approved for lung cancer?
No, just a question here, Evelyn. Yes, Dr. Wafa, but the question was we should do the PD-L1 for metastatic colorectal cancer, Dr. Hello. First line is we are doing more the MSI.
We should do the MSI. The MSI. The MSI
is really important. And for Dr. Wafa, today we have more than 12 indications for testing PD-L1. In lung cancer, it's standard of care today, because when it's more than 50%, we can give the immune checkpoint inhibitors directly. We have many tests, more than 5 tests today in PD-L1. Every company has its test, so it's being really complicated to do a comparison between them. But today in colorectal cancer, we don't have, for example, indication. For example, in cervical cancer, in head and neck cancer, and in many other cancer, around 12 cancer, we have the PD-L1 today in gastric cancer, in esophageal cancer. It's really an important tool.
Mm-hmm. Thank you.
So I have here, we have a few questions about breast cancer, and I prefer to keep this for the next breast cancer session for Dr. Marwan Abu Farah and Dr. Muhammad El-Sisi. Either you send it by email and we reply, or we wait for the session of ABC. Today we'll try to focus on the precision medicine. Another nice question from Dr. Manal Deglawi. Maybe we should think how to push the tumor cells to differentiation other than to kill them. Probably that's the role of immunotherapy. Dr. Hampig, Dr. Evelyn, maybe we should think how to push tumor cells to differentiation other than to kill them. That's what we are doing now with the in CML and in immunotherapy. We are trying to survive with what we have. Okay, I think with that we have to go for the next sessions, dear panelists.
Thank you for this great discussion. Thank you for all your efforts, Professor Farhat and Professor Khatib.
Thank you all. And now we are going to the second session with the president of the CRG, Dr. Fadi Farhat. I don't know if Dr. Maher and Dr. Mirbat, are you with us?
Yes, yes.
Yes, we are. We are enjoying the session.
So, Dr. Mirbat, would you like to present Dr. Fadi Farhat, and Dr. Maher then will present Dr. Basim Bahrani?
Yeah, sure. Dr. Maher, you can go ahead, and I will go for Dr. Basim.
It's easy. You can say.
Dr. Farhat, yeah, Dr. Farhat is well-known doctor. He's, so do I need to introduce him, Dr. Fadi?
Introduce me as your friend. It's the most important, Maher.
Yeah. The Dr. Fadi Farhat is the head of hematology oncology department. in many departments, I always saw you in San Joseph, right, Dr. Fadi? San Joseph University, I told you, and you can tell us how many departments you working for.
You know, in Lebanon, since it's a small country and many centers, the majority of doctors works in many centers. So we like collaboration. We cannot get a government. Yeah, we cannot choose a government, but we like collaborate. So on our level as doctors, we are doing well. But so every Lebanese doctor almost is working in many centers, since it's a private activity.
So tonight you will talk about speak to transforming cancer care through comprehensive genomic profiling, the role of liquid biopsy. Please go ahead.
Thank you very much. Can you see? Do you see my?
Yes, we can see it clearly.
Yes, thank you. First of all, I would like to thank all the present doctors for their presence with us after this day work. I thank Dr. Sami Al-Khatib, the General Secretary, the President of the AMAC, for his support. I would like really to thank Dr. Evelyn for her presentation, and Dr. Wafa. It was really nice presentations. A lot of challenges, lots of ideas, and the discussion opened the floor for the next presentation. Here, you discussed a little with Dr. Evelyn about the liquid biopsy and how practical is it. I will not go through this slide now, because we know very well that what we are targeting is, as Dr. Wafa Abul Aynan presented, we would like to go deep in the chromosomes of these tumor cells to understand what's happening, and the main goal is to know what is the driver alteration. Is it a mutation, amplification, insertion, deletion, or others? So do we know what kind of alteration is involved in the growth and the development of the cancer, so in the pathophysiology of this cancer? Now we understand very well that there should be always a driver alteration. And this genomic profiling, which we are talking about through NGS or others, may identify potential driver alteration. So even if we don't find nowadays the driver alteration, I personally think that we will find it later on. With time, we will learn more and more. So the genomic profiling that we are working on with the help of the bioinformaticians is intended to identify this alteration, whatever it is. And when we discover this alteration, we probably can treat more precisely, and as it was said by our colleagues in the first session. So the idea is to improve the outcome, to decrease the toxicity, and to decrease even the economical burden of the treatment. Thus, the profiling, the genomic profiling, should be in the center of the personalized healthcare nowadays. It will help us to give the right treatment for the right person in the right time. So this is about genomic profiling in general. What about the comparison between solid and liquid biopsy? We know very well that for the solid biopsy, we need an invasive procedure. It might be done in some cases, and others, like when we have necrotic tissue and quickly or rapidly growing tumor, we might have necrosis. So it might be not be feasible. We might have less samples. For example, in lung cancer, we have sometimes we need more time for surgery, which is not the case for liquid biopsy, and it is not helpful for the continuous observation or surveillance, because we cannot take a tissue biopsy every time. And remember that single biopsy, will come to it, might not be enough. While in liquid biopsy, it's really less invasive. It can be performed easily when it's inaccessible to have a tissue biopsy. It gives us an option when we have necrotic tissue, because the tumors, the ctDNA and the tumor cells will be in the blood. It requires less surgical intervention, and it's feasible for the long-term follow-up. Like when you do a tumor markers, it's very nice if you can do a liquid biopsy repetitively to know what kind of alteration we had initially disappears and what kind of alteration appeared after the resistance. And it can also, since the blood is circulating in all the organs and all the metastatic site, it help us to capture the heterogeneity, the difference between these metastatic sites. So I mean by that, so if we have different sites and we take only one tissue biopsy, we can probably with the liquid biopsy get a sample from each site, since it's all circulating in the blood. You know very well that in the blood vessels, the healthy tissue and the tumor tissue with time will go to apoptosis, and thus we will have in the blood vessel the circulating tumor cells from these tumors and metastasis. We might also have the healthy cell-free DNA or tumor cell-free DNA and RNA that will be circulating, as you can see here, the healthy cell-free DNA, which will come from normal tissue, and the tumor DNA coming from the tumors. Also, we might have the extracellular vesicles, membrane encapsulated extracellular vesicles that can be released from healthy and the tumor cells. So here we are exposing the challenges. As you can see in the blood, you can find everything. And we will have also the tumor-educated platelets that might contain tumor-derived RNA in the blood. So a lot of things that you can detect in the blood, but we will see later on what this will give us. This will lead to that even if we have circulating tumor DNA, we have to understand what's the percentage of this tumor DNA. Now we have to understand that we have also plasma and serum, and we all the time try to take from the plasma, because in the serum compared to the plasma, the serum contains more cell-free DNA that we do not need, because we are trying to target the DNA related to the tumor cellular DNA. So the cellular free DNA that is present in the serum will not help us, will not guide us against the tumor cells. What we need is plasma. So remember, that's why always we ask for plasma. And as I told you, the ctDNA is a part of the cellular free DNA. So when we have a low percentage of ctDNA from the CF cellular free DNA, we will not be able to capture the mutation or the alteration found. For example, look from the ctDNA might be from 0.1 to 90, up to 90% of cell-free DNA. You understand very well that if the percentage is 1 or 2%, so detecting this ctDNA will be really almost impossible to guide our treatment. And also, it's important to understand that the ctDNA will increase with time due to the progression of the disease. So as you can see on this graph, with the progression of the disease from stage 1 to further studies, you can find that the percentage will increase. This also might push us to understand, to realize that doing liquid biopsy early might not be, to try to detect the ctDNA might not be the ideal thing. So how we detect this alteration, also Dr. Wafa mentioned this. So we have different types. It's just to understand. It might be a base substitution, as you can see here. It might be an insertion or deletion. from one chromosome to another. It might be a copy number alteration, amplification, and it might be a rearrangement. And we have different type. Remember that even in the same gene, we might find different type of alteration, but it will not have the same impact and the same meaning. For a simple example is the HER2 amplification and the HER2 mutation. So the HER2 amplification has an important significance in the treatment and leading the treatment in HER2 positive breast cancer, while the HER2 amplification is not does not have the same meaning and will not have the same impact of treatment. Also, as Dr. Wafa Abul Aynan, who led the way for this presentation, said that we have different type of methods to evaluate to detect these alterations, this genomic alteration, the PCR-based techniques, the hotspot NGS, and the comprehensive genomic profiling. I will not go through it, but just I've put that these methods are still important in different indication. For example, PCR-based has a high sensitivity, but it's really directed for a limited number of alterations. So yes, the PCR is important, but for specific indication. And for also the comprehensive genomic profiling is important when you want to have a broader panel. So you have to use this comprehensive, this genomic profiling. We understand very well that it's more technical, but we have as clinician to look to this difference in practice. Remember that the liquid biopsy started to be approved since 2016, and nowadays it's really approved by NCCN and the International Association Against Lung Cancer. And it's used practically in many of the trials that there are nowadays in our daily practice, like the SOLAR-1 trial, where we used alpelisib, and the aim is to track the PIK3CA mutation. So we will talk about it also later. The PIK3CA mutation might be detected by the tissue biopsy and the liquid biopsy. And it was very nice because the trial was designed from the beginning to detect it by both ways. For those who participated in this trial, we participated. We used to take the biopsy for reading, tissue biopsy, and we to do the liquid biopsy. And by the end, they did the comparison, and they showed that you can use the liquid biopsy to detect this PIK3CA. It will give the same meaning as in the tissue biopsy. In the colorectal also, we know that we can monitor tumor recurrence and we can detect resistant mutation for the patient treated with anti-EGFR. For esophageal also in M1, for non-small cell lung cancer, for all those who are practicing in lung cancer, we know very well that because of the hardness, the difficulty of retaking a biopsy from the lung or from the metastasis, when we have an EGFR mutation and it's treated by the first generation or the second one, on time of progression, we go for a new biopsy, but we try to do it liquid biopsy. It's less invasive, it's more accessible, and it's also resulting in giving good results. So the guidelines nowadays are using liquid biopsies. What are the concordance between the solid and liquid biopsies? And I like this topic because 5 years ago and maybe more, we used to discuss to debate about the solid and the liquid biopsies, and you will have the control and against and with this activity. But remember that the tumor is heterogeneous in general. We have different type of tumors, even if it's the same adenocarcinoma, the same breast or lung, it's different when it comes to different people. So there's inter-tumor heterogeneity, and there is in the same tumor also different clones. And we knew about that from the small cell lung cancer 20 or 30 years ago. We used to say that there is 2 clones, probably one sensitive to chemotherapy, the other is resistant, and when the first will disappear, the second will have the place, etc. It was ideas. We know very well that in gastrointestinal stromal tumor, we might even have different mutation and in different foci of the tumor or in different metastatic sites. That's why we used to go to do surgery when there is a progression in only one side. So the tumor is not homogeneous, it's heterogeneous. In different metastatic site, it might be different, and even in the same site, it might have different clones. So this is very important to understand, that if I want to take data from this clone and this clone and this different clone from different metastases, it's not easy to go for a tissue biopsy. And even if nowadays, when we have a progression of a lymphoma or breast or other tumors, we go for a biopsy. But how much can you do? How much biopsies can you do when you have different sites of metastasis? We used to do liver biopsy in a case of breast cancer relapsing a few years later, in order to see if it's the same tumor, and even sometimes you compare. But how much can we explore this tissue, and how aggressive should we be when we might have different methods? So talking about the comparison between the liquid and the solid biopsy, you might have a perfect concordance, you might have a good concordance, and you might have a low one. So it's different scenario that you can have practically. And here we are giving a very nice example. It's a case, I'm sure it was in a trial, because nobody will go to do a brain liver biopsy 1, liver biopsy 2, and subcutaneous lesion. But look, for a tissue biopsy, we could find two. I will say it differently. In the liquid biopsy, we had four alteration: BRAF, KRAS, NRAS, and GFR alteration. And when we went through every metastatic site, we couldn't find in the brain. We found only 2. In the liver, first liver, we found the 3, not the 4th. In another liver, we found 2, and in the subcutaneous lesion, we found 2. So there was different significance of the biopsy. And if you follow the tissue biopsy in this case, you will miss probably one of the mutation, and we don't know which one is the driver, but we will miss them. While in the liquid biopsy, you can find it all. And again, look to the right, the pan-tumor study, a big number of tumors and patients, and there was a 75% concordance between the tissue and the liquid, which in my opinion is good for the time being. So if I want to have a message, the discordance between mutation profile in solid and liquid biopsies might happen because liquid biopsy can capture the genomic heterogeneity of all cancerous lesions, all sites. So the ctDNA might detect mutations, alteration that the patient can have in different metastatic site. But also, since the expression of the ctDNA and the cell-free as percentage, and the cell-free DNA might be low, in some case we might skip some of these alteration. Now I remember that the question for Dr. Evelyn, the ideal, if there is no economical challenges, Dr. Wafa, the ideal will be to go for a tissue biopsy and the liquid biopsy, do both. Then you will have all the kind of mutation, and to do a follow-up later with liquid biopsy. It's ideal, but it's not feasible for the time being. Let's take some example about the ctDNA. Nowadays, we are using in the late stage mainly. The idea is to select new lines of therapy. When when we have a progression in the breast cancer, hormone receptor positive breast cancer, we go for the mutation of PI3K, PIK3CA mutation. We do it in the later line. No guidelines will tell you that you have to do it in the first line or in the adjuvant setting. So nowadays we do in majority in late stage diseases in order to understand what mechanism of resistance is really now present and what can we do to help the patient. Knowing that, for example, also the ESR1 might not be detected in the first line, it will appear after the appearance of the resistance of the estrogen receptor pathway. But also we can use it in early stages diseases to understand the prognosis and to choose the initial therapy. We can do it for surveillance and monitoring, and the ideal will be later on for early diagnosis. And I am sure this will come later on because the progress is really here, and I hope we will see the use in subclinical cases to discover subclinical diseases. And it's important because the ctDNA level might be an early marker for therapeutic efficacy and might be a predictor for a long of survival in non-small cell lung cancer. Here is the example of the SOLAR one, as I told you. So if you look here for the PIK3CA alteration found by tissue biopsy or liquid biopsy, we have a concordance in the median PFS, almost 11 months of PFS with a significant hazard ratio in both. So you can use either way, either methods to detect the PIK3CA mutation. And for the ctDNA, we have to know that the targeted therapy based on this method, the liquid analysis, might show a clinical benefit, yes. So it might help or replace the solid biopsy in some cases in the journey. Now, since one of, we thank Roche for the sponsor for their support, we will go through the foundation one liquid biopsy, and we have to tell that the foundation one also might give you more information about the tumor mutational burden of the disease. And here the debate is about the importance of the TMB. We heard the discussion about the MSI and PDL1, and personally I think that TMBA, the tumor mutational burden, also is important, but it's not really yet clear where to establish it. In some studies and trial, like with durvalumab, we know that the TMB showed an importance prognostic factor, but not in all on other indications or other drugs. So the foundation one liquid diagnostic evaluate a big number of genes, but as it was said previously by Dr. Abul Aynan and by myself, it's not about the number, it's about the importance and the practicality of these alteration found. Can we target it? Does it have any meaning to understand the resistance? Some of these genes alteration will simply have a meaning for understand the aggressivity of the disease, like the P53A, P53 or others. So the liquid biopsy will extend the benefit in the comprehensive genomic profiling. Remember again, when you cannot take a tissue biopsy, for example, if you deal with foundation one, if your tissue biopsy is not enough, they will go immediately to the liquid biopsy, which will help us to find the actionable meeting. So when is really the value added for the genomic profiling? It's when you have you don't have enough solid tissue. It's inadequate. It was not well conserved, and Dr. Wafa talked about the conservation of the sample. And please remember that is even in Lebanon, in big centers, in some of centers, it's still a problem. How do you conserve the tissue? So many times we send the the tissue for analysis, and they tell us it's inadequate for a reading. So it might be inadequate, it might be insufficient, or it might be exhausted. We did the different alteration and we don't have more enough tissue. And it might help when we have a recurrence or resistant mutation. We can do it if we cannot have a biopsy, when the biopsy is difficult. And in some cases, I think that it will give complementary information in the future. So here's some example about what can be found in the foundation liquid biopsy in non-small cell lung cancer. Look to the panel. We have the needed panel of EGFR, RAF, ALK-ROS, HER2, MET, RET, and TRAC. These are the needed panel in non-small cell lung cancer. Added to that, we have the MSI. And for those who would like to use some specific drug, the TMB might helpful here. In the breast, we know very well the panel, the HER2 ESR and TRAC BRCA panel and PIK3CA. With the MSI nowadays, with the immunotherapy and triple negative, we know that it's important. So as you can see, in different indication, we have really different panel, and it's approved for foundation 1 liquid biopsy, as it's approved for other. It's not only approved in foundation 1 liquid biopsy. You know very well that there is other companies doing also liquid biopsy. And what's interesting when you do this, it's not, we are not going to do a specific target. We are studying the whole gene. For example, here, the EGFR, we will study the EGFR. You might have some alteration and it will be written of non-clinical significance. So, but you will have it. It will help us for later on to understand the genome alteration globally. So again, this is a slide. I'm sorry, it's a repetition. So my message from this presentation is that liquid genomic profiling has a high potential to inform, to help in the taking a clinical decision during the long journey by providing minimal invasive access to genomic material of normally inaccessible, specifically in cases of lung tumors or some deep tumors and non-accessible. It's also helpful when we have many metastatic sites. It's helping by capturing the intrapatient genomic heterogeneity. So when we have different sites, we might have different form of alteration. So it will give us a global view about these alteration. It might help in detecting minimal residual disease. We know it works very well in hematological diseases, but not in solid tumors. And it might help after first intervention in early progression and else. And it might complete, not replacing for this time being, I think, but it might be completing the solid biopsy. And as you can see, it has the potential to complement for all the journey. It's FDA approved, and it's really, in my opinion, capturing a lot of important information. And with that, I thank you very much, and I give the floor for the panelists, Dr. Mirvat and Dr. Ahmed. Thank you very much.
Thank you very much to Dr. Farahat. That was excellent presentation. And I think you're hitting a lot of important points, and we'll come to this in the discussion. And I can see that the Q&A box had plenty as well. So we'll go for our next speaker, Dr. Basim Bahrani. Dr. Basim Bahrani, he is a medical oncology consultant at National Oncology Center in Oman. Dr. Bahrani, he will give us a talk about how to afford clinical trials access after genomic testing. Dr. Bahrani, the floor is yours. Thank you.
Very much. The next 20 minutes, I'll go through most of the next 20 minutes, I'll be talking about how to afford clinical trials access after genomic testing. My presentation will be more of clinical, not of clinical, but more of health economic perspective, and we see how we can use health economic to get to afford those very expensive medication of the recent clinical trials. To go next now. The cost of cancer care, the total direct healthcare cost of cancer care is increasing. If you compare, for example, from 2009, it was in Europe, it was 51 billion. And in 2020, the expectation was 158 billion euros. The cost of cancer care is around 4 to 6% of all health expenditures. Healthcare problems, there's an uncertainty in the effectiveness of healthcare technology may lead to welfare loss. Effective technologies should be selected in order to prevent welfare loss. So countries and society cannot provide all effective health technology to everyone from public to resources. There are issues with coping with many new innovations, new medications. There are issues with coping with escalating cost, coping with inequalities in access, and also in coping with inequality in needs. What are the challenges? There's a considerable gap between market approval and access to expensive drugs. And there are also considerable gaps in cost and availability of expensive medication. So application of value-based pricing of medicine is a major challenge. So organized purchasing power to negotiate price rebates and price transparencies and reform pricing of expensive medications. That's early regulatory approval is insufficient to ensure access. And in situation with high unmet need, clinical trial are an important access tool for innovation of new product. What is the difference between cost effectiveness and cost saving? Cost effectiveness criteria is applied in many countries to increase the evidence-based decision relating to pricing, reimbursement, and formulary listing of new medications. We need to set fair expectation between cost effectiveness and cost saving. If you want to have a cost effectiveness, an example is when you diagnose patient in early cancer stage. But if you want to talk about cost saving, is to have a diagnosis in terminal cancer stage. How we do assessment of cost effectiveness? There should be value for money. We need to compare a policy relevant technology. We have two options. If the new technology results in equal health gain, it is cheaper. And if the new technology increase the health gain, is the increment of health gain achieved at fair incremental cost? So economic evaluation alongside clinical trial is very important. We need to analyze economic consequences of efficacy, safety alongside with clinical trial. We need to naturalize the economic trial, analyze the cost effectiveness under natural conditions. In economic modeling on the basis of clinical trial data, we need to accelerate to longer time horizon or specific population or countries. So the manufacturer asks for a price above the product. If the manufacturers ask for a price above the product value, we need to negotiate about the price. If the manufacturer cannot produce the price, we have two options. Either we purchase the medications at the price which is above its value, or not purchasing the breakthrough medications. The other option we'll have is managed by entry agreement. So under uncertain health outcome and budget impact of innovative pharmaceutical product, this is from the perspective of payer in several countries. The price of new technology is often above what is affordable or what is the value-based. Potential solution for both problems to improve patient access, risk sharing is by using risk sharing agreements. So how to select among managed entry agreement? We need to see which agreement can be delivered, deliver the necessary price reductions, which agreement is acceptable for the manufacturer, which type of uncertainty payers want to manage, objective measures for the cost and outcome parameters, low cost of implementation, including measurement of the outcome parameters, and very important is legal framework to support confidentiality. What is the consequences of confidentialities? Is decreasing the number of published risk sharing agreements and increasing number of confidential managed entry agreement. This will help us in convincing the manufacturers or the companies to reduce the price by making the agreement confidential. So we not declare it to electronically or through the internet, because drug company can give different prices with different countries. So how to manage entry agreement? Manage entry agreement by risk sharing to reduce uncertainty of payers, or confidentiality to facilitate different pricing in order to increase patient access. The main elements of managed entry agreement is we keep usually the original list prices it's kept. The manufacturer take responsibility for uncertainty in cost or outcome through payback mechanisms. I'll give you an example later on. The agreement remains confidential. Price volume agreement, price decrease with a volume increase. After a threshold, the product is free of charge. Or we go for pay per performance. It's like give money back guarantee in case of adverse event, money back guarantee in case of adverse event mortality, full outcome guarantee, money back plus cover cost of all treatment failures like mortality or adverse event. So what is the value-based price? New technology is cost-effective at a given price, or the price premium of a new technology can be justified by additional health gain or saving in healthcare budget. So toward value-based pricing to boost cancer research and innovation. So value-based pricing of medication has exciting potential to help to improve patient outcome at affordable cost. Other names for value-based pricing like performance-based pricing, managed entry agreement, risk-sharing outcome-based scheme, access with evidence development, and those all have the same meaning. So value comes from achieving the highest possible health gain, which is the outcome for patient, measured against the total cost of the care. Under or overuse of treatment or use of inappropriate condition can compromise the value. There's talking about cost, value, and sustainability. We need to quantify the value of new treatment. Value should becomes the criteria for inclusion of treatment in clinical guidelines, marketing approval of new treatment, or setting price of treatment. There should be a system where inflation of drug costs is far exceeding all other commodities is not sustainable, and government should approve new treatment and control drugs registration based on value pricing. So this is the perspective from the buyer. In the past, patients will get a prescription and he pay for it. What's happening now and where we're heading for, then patient come with a disease, given prescriptions, we need to have the outcome. If the medication works, is the medicine safe, what the specific population with highest likelihood to respond and tolerate, then they will end up with the payment based on performance. So the paradigm, there's a paradigm shift in medical treatment. So purchasing medical technologies, ending with purchasing health. The main issue with that is new drugs in a disease area with huge public health priority. Drugs is not good value for money with significant budget impact. There's uncertainty in the number of patients, uncertainty in health benefit, for local patients. So the main scenario we'll have, either the option one will be we cannot afford the medication and there's no reimbursement. Option two, there's reimbursement. And option three, there is reimbursement but managed by entry agreement. So you have either go as one step or two steps approach. One step approach, which is not recommended now, is we submit the critical appraisal, there's no negotiation, and we buy the medications. The two step is by doing submissions, critical appraisal, recalculation of the cost effectiveness and other decision criteria in recognition phase in order to facilitate confidential price reduction or risk sharing managed by entry agreement. So what I recommend is we should have narrow target patient group. We do risk status, only high risk patients might get those expensive medication. Positioning the medications going to second or third line, so reducing number of patients who can use those expensive medications. We work on to reduce the price by having transparent price reduction, confidential rebate and discount, financial risk sharing, price volume agreement and others, and volume relate rebate. So we go with risk sharing. I'll give you a few examples which I've done in Oman in the past. For example, when we first time introduced a my profile and also the test for the breast cancer Oncotype DX, we decided to have risk sharing with the drug company. So the agreement done with them that, okay, we'll bring the tests in Oman in one condition. If the patients saved chemotherapy, then we'll pay for the test. If the patients end up having chemotherapy, then will be no payment. And they agree for that. And we managed to save around 20 to 30%. The other strategy we've done with one of the companies where we told them you like immunotherapy for lung cancer. What we told them, okay, if patients did not respond, we reimburse the vial to us. So we do an assessment after 3 to 4 cycles. If the patient improving or responding, we continue paying for the companies. But if the company or if the patient, for example, has no response, then the company will reimburse the whole vial back to the hospital. This is the way where we go and do risk sharing with the drug companies. Other way of doing it is by having international collaborations. Third thing is special willingness to pay the threshold. It's very important to have a threshold. We say we can pay up to a certain amount of dollar or reals or pound or dinar. So when you negotiate with the company, say, okay, you're telling us the vial is $5,000, we can pay only 3,000, take it or leave it. By this negotiation, we managed to get medication at a lower cost. We can adopt the pathways. Sometimes we use in Oman, we have used the biosimilar to force drug company to reduce their price. We managed with one of the biosimilar to reduce the price by 45%. One of the medications, the cost, we were used to pay around 1,200 Omani Riyal. We managed to get the same medication biosimilar from India for 650. The company matched the price and gave us around 50 or 60% free medications. Company cannot reduce the medication price, but they can give free vials to compensate for the difference. We should have special budget allocated based on multi-criteria decision analysis. We need to guarantee outcome. So paying for performance might help us to reduce the number of patient use or reduce the cost of that medication. and using the outcome-based risk sharing. Here we need to convince the administrations, the policymakers, that it is very difficult when you're buying a food, when you have medications, you buy a food, but you pay for a Ferrari. That's not fair pricing. And also, if you want to buy a Ferrari, but you want to pay for a Ford, that's also not feasible. I come to the end of my presentation. Thank you very much for listening.
Thank you very much,
Dr. Mirvat and Dr. Maher, the floor is yours. Dr. Reem also, he joined us. The floor is yours to discuss and to take the questions.
Yeah, ladies first, maybe.
Ladies first, so Dr. Mirvat and then Dr. Reem.
Yes, thank you very much, both speaker. It was excellent presentation, both, and I will start first with Dr. Farahat regarding the hot topic regarding the liquid biopsy. And we know that the tissue is the gold. However, we know that the liquid biopsy, it's accessible, it's an easy, and we can have it as you presented in your presentation. So my point that what is the barrier for the liquid biopsy, specifically calling for the validation and the sensitivity comparable to the tissue, specifically not all the tumors can shed tumor cells to be detected in the blood. So what do you think?
Thank you very much for the question. I checked in the question box, and it was there's some similar questions about why if liquid biopsy can replace. Remember, tissue biopsy is still the gold standard.
Yes.
But liquid biopsy, as I said, might replace when you do not have access to the tissue biopsy or when you need a repetitive biopsy. Personally, I think that liquid biopsy is the future, but it's not for the time being the guidelines. The guidelines now is the tissue biopsy. Because till now, we cannot detect all the ctDNA. You know that the normal tissue will release cell-free DNA, and we will have a lot of cell-free DNA. So when you will detect all DNA, the proportion of the ctDNA, the tumoral DNA, will be in some time will be so low, about 1 to 2%. So you cannot conclude from this percentage the reality of the disease. So, but when you have let's say a big amount of ctDNA in the blood, thus in this case it will be representative of what we have in the tumor itself. So again, I will resume it this way. The ctDNA, the liquid biopsy, has a lot of advantage because it takes these tumor cells and the ctDNA from all the metastases and from different clones of the same metastasis, and it might be longitudinal. We can do a repetitive exam since it's only a blood exam, but we can miss these tumors that have a low burden and secreting a small amount of ctDNA. So for the time being, the golden standard is to go for the tissue biopsy, and when we cannot, we go for the liquid biopsy. Why we cannot use it liquid again? Because in some cases we have a small amount of ctDNA in the blood, which is not allow us to get an objective result.
So how do you frequently can recommend both, specifically as you pointed out, the tumor heterogeneity, sometimes we are not able to find a driver mutation. So in some cases, we may go for the tissue biopsy. I didn't find any driver mutation, and we have to go for the liquid biopsy, and we found even what we didn't find in the tissue. And we have some cases reported for negative for EGFR, and we found it in the liquid biopsy. So how frequent you could recommend, or which cases you can be suspicious?
So if you have a positivity on the tissue biopsy, you will continue with the tissue biopsy if needed.
Absolutely.
But yeah, I mean, but you cannot do it all every 3 months. You will do it whenever there is a progression of the disease. And if it's negative on the tissue biopsy, so it will be the liquid biopsy. When to repeat it? When there is a progression usually, or if you are seeking to see if there is any MRD, minimal residual disease. But for the time being, and because of the high economical burden of such tests, what we can do is only doing this test whenever there is a progression to detect the resistant mechanism. So you repeat either the tissue biopsy or the liquid biopsy outside the protocols trials only when there is a progression. And how frequent, it depends of the number of these relapse.
Okay. Thank you.
Thank you.
Dr. Reem, do you have any?
Hi, thank you, Dr. Farahat, Dr. Al-Bahrani, for those excellent presentations. Dr. Farahat, I have one question. I'm not sure how available liquid biopsy in Lebanon, how frequent do you use it? I know the economic burden for the patient, it is not covered by our insurance. So in Jordan, we don't use it that frequent because it is not covered. Do you ask for it if the patient, for patients who are who progressed on all types, on all lines of chemotherapy?
Yes.
For investigational drugs, you know what I mean?
Yes. Nowadays, we have at least 2 FDA-approved liquid biopsy tests. We have the Foundation one. We have also the Guardant. And I think even Caris now is doing that, but I don't know if they are FDA approved. So we have at least 2 and maybe more. I don't know. Are we using it? Yes, we are using it, and mainly when we have difficulties to get the tissue biopsy, and we need data about the genomic profiling, we go for the liquid biopsy. Also, we do it in some cases, for example, in lung cancer, when there is a progression, and we don't like to go for a tissue biopsy. We prefer the liquid, since some kind of mutation like the T790 is detected by the liquid biopsy. So we do it. Yes, it constitutes almost 30% of all our genomic testing.
Okay. I have another question for Dr. Al-Bahrani. I'm not sure about the coverage for your patient, or I don't know about the health system in your country. Are your patients all in general insured by the government or self-paid for their cancer treatment?
Yes, all Omani, they are not insured, but all treatment free for all Omani. Non-Omani, they pay. But to provide free medications, we need to reduce the price. Actually, the price in Oman, at least half of those prices in our regions. And that happens.
All Omanis are covered, insured?
Then they're not insured, but government pay for all their medications.
Yeah, it's the same, like almost the same in Jordan.
Yes.
The government pay for their cancer treatment.
Yes.
So that's why you go, you try your best to decrease the cost for the new medications.
So, I'll give you one example now for the liquid biopsy. Liquid biopsy, it costs around $5,000, right, Dr. Fadi?
Yes.
Okay. Now, if I'm doing a test patient to patient basis, I cannot negotiate with the company who's making the liquid biopsy. But if we have collaborations with 4 or 5 hospitals, and we tell them, okay, we will do 100 tests per year or 200 tests per year. Then give us, with every 10 tests, give us 1 free. They will give, because now we're dealing with bulk. In that case, people who cannot afford, we can use those free testing. So this is the way we can negotiate. But if you, or you tell them, we cannot afford 5,000. If you want the test to be done, we'll pay you 4,000 or 3,000. This is the fair pricing for that test. So other thing is to have fair price. The fair pricing comes from the payers, not from the drug companies. So we need to.
So it's true, Dr. Bahrani. This will depend from a country to another.
Yes.
It's different policies. For example, in Lebanon, we have mainly a private. So the government will not go and deal. While in Kuwait, in Qatar, in Bahrain, it's centralized. But I wanted to tell you, yes, how to afford drug, it's okay. But I wanted to hear about the accessibility to research, to trials. So you should know, it's important for the audience, when you do a molecular profiling, there is a frequently ongoing trials where you can put your patient. So either you ask for the drug for compassionate use, and I have a lot of patients using compassionately drugs that are not yet approved in Lebanon, that are not yet commercialized. So if you do the genomic testing, you can check, you see which trial is ongoing, which medication is approved. If it's not on the market, you can search and contact them for compassionate use. Either you can send your patient abroad to participate in trials. And in some cases, they might pay the travel, the hotel, and also. So pay attention when you read the report of this genomic profiling. If it's done outside, try to look, you might find ongoing trials with the free of charge drugs.
Yes, I know, it is true. Putting patient in clinical trial will save a lot of money.
Yes.
But on the other hand, if you see the clinical trials around 10 years back, you hardly found patients recruited from the Far East. When they came and told the manufacturer that if we are not involved in clinical trial, we're not going to approve your medications. You see most of the clinical trial now, we have patients coming from China, from Korea, from Japan, from those places. This is what
but the compassionate use, Dr. Bahrani, is different than the clinical trial.
Yes,
the compassionate use, it will be sponsored by the company, and so it's for example for sulperbactin, or for RET patient positive, or for poltazumab for a patient with lymphoma. This is they afford for a patient who can have specific criteria. It's out of the clinical trial, and the compassionate use, it's all over the world, specifically in the North American and Europe, as Dr. Farahat pointed out. And I think it's now available in the Gulf area, and we have a couple of patients under compassionate use. It's not a clinical trial, it's just only criteria to fit for the patients. They can provide us with the medication.
Yes, I know that, but why for our patient should wait 5-6 years till the trial finish and patient becomes uncompassionate? This is what I'm talking about. We should be part of their clinical trials from the beginning. We should not wait for 4 or 5 years to be medication to be available as a compassionate use. So if our governments or our regions make that rules, then our patient will be able to use those medication even before it's available at compassionate use.
I think the point of the clinical trial, it has 2 parts. The first is that regarding about the logistic and regulations in every region, and the second part is the because of the trust and having a research center in every in the centers. And so because we still have not a good reputation as a Middle East region regarding conducting clinical trials or participating as recruiting patients, and also because of the logistics in many of our centers. This is, I think, it's a huge barrier. It's not only the barrier regarding that most of the studies conducted in North American and in the Far East, and then we are following them.
But I don't agree. I think if we cannot, if a government or a country can afford paying yearly $100-200 million on bringing medications, they should be afford establishing the infrastructure for clinical trials by
Yes,
having
agree.
proper. Yes. So
sorry, go ahead.
They should invest. This is one. The situation now completely different than the situation about 10 years back. Now, if you say in the Gulf, Oman, Qatar, Kuwait, the number of doctors trained in North America is huge, and they're coming back. And while they are there, they've been involved in clinical trial. So what we need is to establish first a proper infrastructure, proper training that's not that expensive. And then once we have that, then we can attract clinical trial in our regions. But if you sit and say we cannot do it, we'll never have a clinical trials like a phase 1 or phase 2 or phase 3 in our region.
Yes, absolutely.
Thank you very much. The discussion will not end. We have many questions, but just a small comment. In my center, we participated in Bolero 2, in Solar, in Mona Lisa 3, 2, in Mona Lisa 7, in Canopy trial, so in a lot of trials. So it's true that we can go and participate in such trials, but one of our problems is the stability. So the FDA or the EMA will have problem coming to us because we are unstable countries. And I'm sure that, as Dr. Bahrani said, we have a lot of trained people. It will come, but you have to claim for it. Okay, so now I will ask the panelists. We have very nice questions. If we have time, we really are يعني قطعنا الوقت اللازم. So maybe we have to stop and
I think
answer questions.
We have 5 minutes, Dr. Fadi.
So Dr. Fadi, if we have 5 minutes, so give me just a couple of minutes. Just before going to take a couple of questions, one for Dr. Bahrani and second for Dr. Farhat, just let me express, I do thank you for inviting me to this great presentations about liquid biopsy and genomic testing, which help this genomic testing help us estimate prognosis, predict response and resistance, and who to benefit from systemic therapy, not only target and immunotherapy, but also chemo. So we can avoid both over-treatment and under-treatment. For instance, Oncotype DX in Taylor X study showed that about 25 of patients received over-treatment, and about 43% received under-treatment because of discordance between clinical risk and recurrence risk, low recurrence score, and those patients had high clinical risk. So it's very important to avoid this patient over-treatment and under-treatment. So let's us go to one question to Dr. Bahrani and the last one to Dr. Fadi. First from Dr. Bahrani. Dr. Manal from Syria, she said, thank you, Dr. Bahrani. Treatment protocols adding one target therapy to many others should look for less cost choices. Do you have any comment? I don't know where is the question, but do you have any comment about this?
Yes. I'm not sure my voice is clear. It is yes. For example, let's go with Roche. There's a combination of Herceptin with pertuzumab. If I'm a decision maker, I will tell them I will not approve your medications or pertuzumab, you give me free Herceptin, because now Herceptin there's a lot of biosimilar, and that can, and they will agree. Now, if you go, for example, with Novartis, they have Ribo in combination with letrozole. They can give us free letrozole when you use ribociclib. So when you have combinations, you go for negotiations, and you manage to get one of those medications at half price or even free.
Thank you for your answer. That's the last one. Question over here for is liquid biopsy FDA approved? What is the difference? As you see, Dr. Fadi, what is the difference in sensitivities, specificity with tissue biopsy?
The liquid biopsy is FDA approved. Yes, true. What's the difference? We talked about it, and for those who are interested, you can go and see, get the link and listen again to the presentation. The future is there with liquid biopsy. Okay, thank you. I would like to thank all the panelists, all the speakers.
There is a recommendation from anonymous attendee that
please listen to the audience and their questions.
Yeah, it is. Yeah, is it time for a MAC to lead the clinical trials in the Arab world, establishing association for clinical trials in the Arab world? So I promise that we are going to do it, and soon, between all the Arab countries and the main cancer centers in the area. So Dr. Fadi, if you allow me just to thank all, before giving the closing remarks for you, just to announce that our next activity will be on July 6th about breast cancer 2 modules, and all they are welcome. So the floor is yours, Dr. Fadi.
Again, thank you very much, all the attendees and the speakers, panelists. The last time we discussed with Dr. Sami Khatib how to reduce the time, because usually it's 1 hour and we are finishing now with 2 hours, 12 minutes. But I think it's exciting. That's why we have still many participants. First. Second, we have another session, and it will be also interesting on precision medicine. It will have place the 27th of July, July 27th, Precision Medicine 2. It's educational, it's some kind of workshop, and we'll have also an international expert. I think it will be as interesting as this one. The next session of ABC breast cancer will be on the 6th of July. Please, we are open for any suggestion from your side. Please, for any person around you, a speaker, as panelist, send us what might be interesting for you as subject and who would like to present. We are encouraging everybody. As you saw, we have a what we call a junior young oncologist corner, where we have always one young with us. Concerning the trials, Dr. Sami, it's very interesting, and we will talk after closing the session by phone directly. Okay. Thank you, everybody, and see you in 2 weeks. Bye bye.
Thank you.
Thank you.
شكرا فادي.
شكرا لكم جميعا. شكرا.
When facing cancer, how can patients know they're armed with everything they need to guide their treatment? Foundation Medicine has developed a comprehensive and validated approach to identify clinically relevant genomic alterations in a patient's cancer, providing doctors an opportunity to personalize treatment options, including targeted therapies that may be more effective and less toxic than traditional chemotherapy. Our approach begins by looking at genes, oftentimes hundreds, that are known to be associated with cancer, using a tool called next-generation sequencing, or NGS, to help find alterations in the patient's DNA that are causing the cancer to grow. Alterations can happen anywhere in the gene, and there are 4 major types. The building blocks of our DNA may be substituted, inserted, deleted, duplicated, misplaced, swapped, or just plain broken. In all of these cases, the cells may end up working differently, causing a tumor to grow. Other tests, such as multi-gene hotspot NGS tests, only look for 1 or 2 types of alterations in predefined parts of cancer genes. Hotspot tests, therefore, may identify common alterations, while overlooking unanticipated but potentially important and actionable ones. By contrast, Foundation Medicine's comprehensive genomic profiling approach broadly analyzes the tumor genome to identify clinically relevant alterations and potentially expands your patient's treatment options. We offer a portfolio of comprehensive genomic profiling services for patients with solid tumors, hematologic malignancies, and sarcomas, including a liquid biopsy service for patients with solid tumors. Our approach analyzes cancer-relevant genes to detect the 4 major classes of alterations specific to an individual's cancer. Some of our services also measure specific genomic signatures, such as tumor mutational burden and microsatellite instability, which can help inform the use of immunotherapies. To find these alterations, Foundation Medicine uses advanced algorithms developed by some of the world's foremost cancer genomics experts and computational biologists. Our approach combines this expertise with our database of cancer genomic insights, one of the world's largest, to continually optimize and improve our algorithms, allowing us to efficiently and accurately discover the unique alterations and genomic signatures in a patient's tumor. We then issue a clear, in-depth report with insights on the patient's genomic profile, as well as associated targeted therapies, immunotherapies, and relevant clinical trials. The end result? Doctors have what they need to make a more fully informed decision, and patients have the assurance that no stone is left unturned in their treatment.
Thank you, Maher. Thank you for being with us.
أتمنى لك ليلة سعيدة معلم. شكرا.
شكرا. إن شاء الله قريبا.
اللقاء قريبا إن شاء الله. إلى اللقاء. مع السلامة. أمان الله. أمان الله.
اللقاء.
سلام.